So, thanks, Sherry. It gives me so much pleasure to introduce Maddie Deutsch. Maddie is the director of the UCSF Gender Affirming Health Program and has been a real leader in so many different spheres at UCSF. From an institutional perspective, I would say she's gold and so important to so much of the work that we do on campus in so many different spheres. Personally, I owe a huge debt of gratitude to Maddie. She has helped me personally, as well as everybody at the UCSF.
One second, my audio went out.
Okay. And so Maddie's just been vital to the work that we do at the UCSF Voice and Swelling Center with transgender voice and neck contour. She has really been a wonderful partner in both clinical care as well as vision and leadership of where our program is going. So it gives me great pleasure to introduce Maddie Deutsch and welcome her to Department Grand Rounds. Maddie, thank you so much.
Great. Thank you, Clark. It's great to be here. It's probably been 9 years at this point since I had been at UCSF for about a year trying to launch this program and grow a multidisciplinary group. And the first place that I knocked on the door was the Voice and Swallowing Center and said, hey, I'm across the street in the Women's Health Center. At the time, that's where we were located. And I do this work. And at the time, it was Sarah and Mark Corey were there, and they were like, whoa, we'd love to do that. We do some of that already. And so, this kind of large group of multidisciplinary team of specialties that we all kind of consortium together for this work, really, you all, were the first to join. So I'm really glad to be here and to have your partnership for all these years and see all the great care and leadership that goes on in your division. So I'm going to go through sort of a potpourri of topics that I thought would be of interest to folks doing the work that you do. So we'll talk a little bit about hormone therapy, just as a kind of an overview, and then really I'm going to get a little bit more into some perioperative hormone therapy considerations. We'll also talk about some updates in Standards of Care 8 and some of the assessment issues and requirements that may have changed. And I'm also going to then actually log into Apex and kind of live walk you through some of the functionality that exists in Apex for things like patient name and pronoun, so that you can understand how to fill in and use those data points with your patients and improve their experience. And then we should have time for questions as well. So let me, and I don't know why this is, I think that my rehearsed timings may be on. So yeah, I don't know how that happened. So let me just get rid of that. Okay, great. So of course I just have to disclose everything in this field is FDA approved, and I don't have any is FDA approved, but off label, and I don't have any financial disclosures. So just want to talk briefly about what do I do, or what does one do to just start somebody on hormones? I think it's probably worth just going through this briefly. So one of the things that I think is important to get across, and this is really not just for hormone therapy, but for the full kind of suite of interventions that people may seek, is that interventions are not tied to an identity. So I avoid things like saying non-binary hormone therapy or non-binary surgeries, and I more focus on the way I phrase it to patients when I'm talking about hormone therapy, which is a little less kind of, surgical interventions are more kind of a bit more quanta in nature. But I talk to patients, are you looking for the maximum degree of medically appropriate masculinization that your body is capable of, or are you looking for something less than that? And it's possible that somebody who has a non-binary identity might want to have quote unquote maximal effects. And somebody who has a binary identity may want, so quote unquote, less than maximal effects. So I really do for each patient an individualized screening of their goals and what is it that they want to achieve out of the intervention. So some of the things that I think about when I'm working with a patient and trying to figure out, what does starting hormone therapy look like? And I think that you could take hormone therapy out of this and replace it with surgical interventions or behavioral voice interventions is, where are they in the rest of their like trans world and their social transition? So, have they come out to people? Are they prepared for all of the kind of not just emotional changes of hormones specifically, but these kind of big existential factors? You all are doing work in facial surgery and voice therapy, and those are two very personal things that I'm sure you know more about this than I do, but those things are really hardwired into your brain. You hear yourself speak, you look in the mirror, and countless times people will want these changes, but also experience some kind of cognitive dissonance or existential angst around the changes. Patients who are asking me for voice therapy all the time say, I'd like to speak to somebody about my voice. I really don't like my voice, but I'm also really weirded out by the thought of like changing my voice. So these are all things that I like to kind of talk to patients about and get an idea of what's the big ecological landscape with this particular patient. And then, we think about pure medical conditions like diabetes and hypertension and how do they interface with hormone therapy. And you don't really need to worry too much about that, but just letting you know that those are things that we think about. So some of the longer term considerations, and, this is, talking more about long-term goals again. I also then reflect back to patients what is and isn't possible. So I make sure that patients are clear that I can't set a bunch of dials. A patient will come to me and say, I want my voice to deepen, but I don't want to grow facial hair. I want to have more hips curves, but I don't really want to have a lot of breast development. And I don't have like dials that I can set. It's kind of like a gas pedal and a brake pedal. Gas pedal is like gender affirming hormones. Brake pedal, particularly for feminizing therapy, is using some kind of testosterone blocker. And that's really kind of all that we have. So another thing of just level setting of what interventions can and can't do, what isn't possible, I think right off the bat is good to reflect back to the patient after they talk to you about their goals and needs. So this, I'm kind of like a pharmacology wonk, so I love this thing. Some of you may not like this at all. But the reason I put this up here is just to illustrate a point, because you might see patients who are talking to you about their hormone therapy, or they're saying, oh, I've taken this, but I want to take that. Or the point I'm trying to make is with this is that you see estradiol is here in this. This is how sex hormones are made in your body, as well as other adrenal hormones. And so it starts with cholesterol, it goes through a bunch of intermediates, blah, 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 and then it winds up here at estradiol. And you can see here that this synthetic pathway, there are other shunts off to things like cortisol and aldosterone. So remember the adrenal structure, salt, sugar, sex. So you've got all those three axes of adrenal activity, and then the sex hormones also come from the gonads. So the point I'm trying to make is that this is why everybody responds differently to hormones at the same dose. They may have different responses. And so I try to contextualize this with my patients. And you might, if you have patients who are coming in and they're talking about, well, my friend is taking this estrogen and they have this happen to them, but this didn't happen to me. Or when I took estrogen, it made my ankles swell, but my friend didn't. It's because everybody's phenotypes for all of these different enzymes in these pathways are different. And so people shunt things to different end products at different speeds, and there are different degrees of homeostasis that are reached. And this kind of matrix is what brings kind of phenotypic diversity to our species. So this is a good thing, but it is definitely why people will have differing effects from hormone therapy, as well as other inputs like the age at which they start and just their general body habitus and kind of other people of the same identified gender in their family who are cis, and what do their bodies look like. So I just wanted to put this out here that even if that hormone therapy is not one size fits all in many ways, including at the chemical pharmacologic level. So the clinical endpoints for hormone therapy for patients seeking this kind of binary transition, not necessarily binary identity, but this kind of maximal effects. I try to get the testosterone into the female range and then just do add back estradiol, also in the female range, arguably at the lowest tolerable dose. And then for trans mass people, I target to get the T in the male range. And we don't really worry too much about the estrogen. We just give them testosterone, and the estrogen, it just doesn't play much of a role. Most of the driver, and I think the voice people probably agree with this, most of the drivers of secondary sex characteristics are driven by the presence or absence levels of testosterone. And estradiol doesn't really do much. It protects your bones, and it has some mood and libido stuff and everything. But the real decider at the end of the day is, where is your T level living? And then for people seeking a non-binary outcome or a submaximal outcome, it takes a little bit more of a clinical nuance. So these are the usual doses that I start someone on, and then I kind of titrate accordingly using lab levels. So that's kind of an overview of what's going on in the world of hormone therapy when you see a patient who's coming in on hormones. So let's pivot now to talking about thromboembolism, because there's a lot of surgery going on in your world, and this question comes up a lot. So if you're just a person walking down the street, the prevalence of VTE the not general population is between 1 in 1,000 and 1 in 10,000. So we have to talk about the baseline risk of venous thromboembolism in an unselected population before we start talking about relative risk in the trans population. So with people taking estrogen, the devil is really in the details. So ethinyl estradiol, abbreviated EE, which is used in most combined oral contraceptive formulations. It has really reliable pharmacokinetics. It has less enzymatic inactivation in the uterus, so there's less breakthrough bleeding. So it has a lot of benefits when being used for contraception, but it's very thrombogenic. In the old days, when most of the contraception that was available were these combined oral contraceptives, the risks associated with unplanned pregnancy are so high that it was felt that the risks of clot associated with this ethinyl estradiol was acceptable as an alternative. So these benefits of ethinyl estradiol outweigh the clot risk. So I'm going to kind of talk to you a little bit about that. Ethinyl estradiol, this synthetic non-bioidentical estradiol, is very thrombogenic. And we accept that risk, again, because of these benefits. And it has to do with what happens when it's metabolized by the liver in first pass metabolism. It imbalances some of the clot factor synthesis, and that results in thrombogenic state. But 17-beta estradiol, which is bioidentical, it's identical to the estrogen hormone that comes out of an ovary, and it's used in most menopausal regimens as well as in feminizing regimens. It's lower thromogenicity. In fact, it's almost no thromogenicity depending on how it's administered. So the data from the menopause literature shows that there's no increased risk of thrombogenic events when you use transdermal estradiol. And it's not the transdermal form, it's the parenteral form. So it doesn't really matter how it gets into your body. As long as it's parenteral, there's probably no increased risk. And it makes sense because estradiol that gets into the body parenterally is coming into the bloodstream the same way estradiol that's secreted from an ovary gets into the bloodstream. And we don't really think that as like 50% of the world who are cis females are just walking around at risk of having a blood clot that's increased just because they're making estrogen in their ovary. The menopausal data on oral estradiol is mixed. The risk is maybe 2 to 5 to 4-fold increase in the menopausal literature. So now arguably people getting menopausal hormone therapy are taking lower doses. And so, does that translate to trans care? Unclear. I'll show you some data in a moment. So, but again, remember the background rate is so low that when we're talking about, we have to talk about absolute risk and not just relative risk. So 2.5-fold increase when the background rate is pretty low should be contextualized for patients when making decisions, should be contextualized when making decisions about surgeons asking patients to hold their estrogen therapy before lengthy cases. Again, the reason that there's a difference between the oral and parenteral thrombogenic risk with these medications is the same as with ethinyl estradiol. There's a tipping of the scales in the liver during first pass metabolism that causes an imbalance in clot factor synthesis. What I will say again is that there's no damage to the liver. It's just a tipping of the scales. It's like you have an old turntable and you put your finger on the record, it sounds slow, and then you take your finger off, it goes fast again. It doesn't harm the turntable. So some of the data shows that studies that were 10 years old or longer, more, showed 20 to 40-fold increase in risk of clot in trans women, but they were using up to 200 micrograms a day of ethinyl estradiol. The typical combined oral contraceptive has 30 micrograms of estradiol in it. So these were people who were taking up to 7 birth control pills a day, and they did not control for tobacco. I don't know why every participant in that study did not get a blood clot. But in more recent studies, like there was a Dutch cohort, and they've actually published 3 reports over the course of about 20 years on this cohort. And it's a longitudinal cohort of thousands of patients that they follow, and they haven't seen any increased risk of blood clot when patients are using this 17-beta estradiol in any capacity. So there's really, for primary and secondary prevention, there's really no evidence to kind of guide any kind of anticoagulation or antiplatelet therapy routinely in people with risk factors or personal history of DVT. In other words, if you have somebody who actually has a thrombogenic risk, they're factor 5, or they have, some other kind of unmeasured mutation, you don't necessarily have to put those patients on anticoagulation or antiplatelet agents, because those treatments have their own risks. And if you have somebody on a safe parenteral physiologic low range dosed estradiol, it's probably not going to increase their risk. So some of the perioperative considerations specifically that come up, there are a bunch of different recommendations that I'm going to kind of scroll through here really quick to kind of think about this, and I'll give you my kind of overview. And we're not going to do any case discussions. I pulled this slide in from something else, and I should have deleted that. Like another talk I didn't plagiarize it. I just pulled it out of another deck. So Caprini scoring, which is recommended by the ASPS. If you take a look at the Caprini score, what you do with Caprini score is you're giving somebody a certain number of risk points, and then that kind of guides what kind of preventive intervention you want to take. So there's all these really bad things that give you a lot of points in the Caprini scoring rubric, right? So none of these, I don't see hormone stuff here anywhere. So, okay, so let's go down. So the last thing on the Caprini list that you get only 1 point for is hormone replacement therapy or oral contraceptives. So they actually lump the two together, even though, as I just kind of went through with you, there's a significant difference in the thrombogenicity between the bioidentical 17-beta estradiol and the synthetic ethinyl estradiol that is in oral contraceptives. Caprini just lumps them all together. Caprini has not been extensively validated, by the way. But in any case, you only get 1 point, and it's the last thing on the list. It's well below other things like varicose veins and having been postpartum, etc. So let's look at how you interpret and apply the Caprini score. So if you have a Caprini score of 0 to 2, you're considered to be very low to low risk with a VTE perioperative incidence less than 1.5%. And the only prophylaxis recommended is early ambulation, and that's it. So there's nowhere in here does it say stop your hormones, take the person off of hormonal contraception before doing the case. So again, if you look back at all of these different values, you can see that if you just have hormone replacement therapy as your risk factor, it's not going to bump you up to a new category. And actually, it's unlikely that hormone therapy is going to be the big decider in what category you land in. It's probably going to be one of those things that gives you scores like that worth 3 or 4 or 5 points on the scale. Okay, I did a little PubMed search. This slide is actually about 1.5 years old. I haven't updated my search, but there hasn't been a great deal of data that I've seen come out since then. I did this just kind of looking for this. There really isn't a lot that's actually been published. There were 43 hits, and then really these were the only 3 that I found that had any kind of discussion. So the European guidelines on perioperative VTE managed prophylaxis, they have in the executive summary, they make 1 mention of estrogen. And it's basically a grade 2C recommendation of over age 70, consider addressing estrogen use perioperatively. So people over age 70 are often not even on estradiol. Now, trans people may be on estradiol over 70, but they're usually going to be on a very low dose and going to be leaning hard on testosterone blockade. So, and it's a grade 2C recommendation, so it's not even a very strong recommendation. ACOG recommends against routine discontinuing of menopausal hormone therapy or contraceptive estradiol and states that overall risk is low. They highlight that and they also, this is really important, they highlight that the prothrombotic effects when present persist for 4 to 6 weeks. So I see sometimes people saying, my surgeon told me that I need to stop my hormone therapy for 2 weeks before surgery because they want to reduce the risk of blood clot, or they're making me go down in my dose for the week before surgery. There really isn't an increased risk of blood clots, but if you do believe that there is, you have to hold the hormones for 4 to 6 weeks. If you do it just for 2 weeks, you're not even achieving the intended effect. But when you're going, we'll go back to that slide when I was talking about all the existential changes that people experience when they undergo gender affirming intervention. Somebody's going to be going for facial surgery and they're going to be having major surgery and recovery and discomfort, and the bandages come off and there's my new me and all this stuff. And oh, by the way, you have to go through menopause for the month leading up to that surgery. It's rough. It's really hard. It's not something that people do well with. US medical eligibility criteria for contraception. So this is going to be purely ethinyl estradiol, which is quite thrombogenic. And this is kind of the Bible for administering contraception. The only time that there's even like a consideration about perioperative hormone use is in a case of major surgery with prolonged immobilization. It goes to category 3, but the surgeries that you're doing, even the long cases, there's not prolonged immobilization. So let's say we say somebody's got a 12-hour FFS case that they're going to have. In cases of we call that major surgery. In cases of major surgery without prolonged immobilization, combined oral contraceptives, much more thrombogenic than gender-affirming hormones, is category 2. Category 2 means that the advantages generally outweigh theoretical or proven risks. So even for something like this, with the thrombogenic estrogen, med eligibility is still not saying to hold the hormone therapy. And so here's just a few other studies that I looked at, and this is a kind of a systematic review, insufficient evidence to support routine discontinuation of testosterone in transgender patients undergoing scheduled surgical procedures, and then decisions about estrogen treatment should keep individual risks. So they kind of did a hedge. So there's no data really to support doing this. And then here's another one: until additional studies are performed, it should be individualized, take into consideration. And this is for contraception. So just, and I'm just going to kind of like, here's just more, here's some more. It's all basically saying the same thing, except this one that was a review article that discussed several studies that failed to find a difference. And then one had an odds ratio of 3.3. And then they concluded from that somehow that it should be advocated that combined or single medicine oral contraception be held for 4 to 6 weeks and restarted 2 weeks. I don't know how they came to this recommendation, because the recommendation is not supported by the data that they found in the review. So really important to kind of drill down and into the literature and, kind of see what is going on in there. Okay, so the last thing I want to talk about before we get into, let's talk about before we go to Q&A, and I'll pull up Apex during Q&A and I'll show you the SOGI thing, but let's talk about this like surgical assessment and preparing for surgery. So this is a general kind of framework for surgical preparation and assessment that I developed some years ago with a vision of implementing it here at UCSF. Historically, there was this, what was referred to kind of colloquially as the WPATH assessment. And the WPATH assessment is, in the old days, it was like you had to go get a letter that said you're really trans, that you're not crazy, and that you have the capacity to provide informed consent. And then that letter was kind of your entry ticket into having surgery. And so that process had so many problems. It created so many problems. The problems it created, number one, was patients had to like check this box. And it created this gatekeeping model that interfered with the therapeutic relationship between a patient and a mental health clinician. Because then it's like, oh, I'm going to stroke my chin until I decide you're trans enough to have this surgery. And then I'll provide you with a letter. And people were like, oh, you have to come for 12 sessions and you have to pay me this much money. So it just created a really bad environment. And then also what would happen is the patient would then show up at the surgeon's office and say, I have my letter. Here's my letter. Now I want you to do surgery on me. And the surgeon would be like, well, I mean, I have to like do my assessment and I have, no, I have my letter. If you don't do my surgery because I have my letter, you're discriminating against me. So it just created an environment that was just didn't really work in my view. What it missed, however, was all of this other stuff. And, if somebody's going to go for a hip replacement, they need to be prepared for all of this stuff. Like, where are they going to go after surgery? Who's going to pick them up and take them home? Do they have like any kind of like cognitive issues or health literacy? Change your bandage 3 times a day for 2 days and 2 times a day for 3 days. If there's more than 50 cc's of output in the drain, you should call. That's going to go right over the head of some people. And because there's so much kind of trauma in the community, there's a lot of social fragmentation. People have a lot of poor social support. People will be like, oh yeah, I have friends who are going to pick me up from surgery. Who? We're just friends, and then surgery day comes and it turns out there's nobody coming to pick them up. And actually they're living in their car. And I don't say all of this to kind of stigmatize anything, but it's to point out that these are the things that are going on in the world around the person going for this surgical event today. So we really created this process where right off the bat, before even referring somebody for surgery, we do this kind of functional assessment. We kind of social support, housing, healthcare literacy. They get their WPATH letter to meet the insurance requirements, and we'll talk about that in a moment. But then the patient's going to have some kind of waiting period. And during that time, things can change. Their housing can change, their social support can change. So we have a social worker with our program, and we implement this framework to try and support patients. And then they have surgery, and then there really needs to be continued reassessment until the surgical phase ends. So this is nothing you have to kind of know anything about. This is our internal flow for how things work when a patient comes for a surgical consult, but just to kind of walk you through it. When a referral comes in, goes through our new patient navigator, a new consult is scheduled and the patient sees a surgeon. If the patient decides they want to have surgery at UCSF, then the surgeon should put in a referral to our social worker, who will then reach out to the patient, do a standard universal assessment. Everybody gets the same assessment. So there's no kind of like, oh, you have to see the social worker and you don't. And then I'll show you how our social worker kind of triages patients. And then eventually, the patient will hand the patient back off to the surgical service, be like, I met with the patient, everything seems rock solid. And then the social worker will remain involved as needed in the case. And, you'd be amazed at the things that come up. Patients are like seem rock solid for surgery, but then you find out that they're living in their car. And the sister who they said is going to be their post-op support actually lives in Sacramento and is kind of on the outs with the patient. And so, these are things that come up, and that's why we think it's good to have this social worker involved. Social worker does a standardized assessment in all of these different domains. This can be done in like a brief phone call most of the time. These are not like in-depth psychosocial assessments. They're kind of brief evaluations, and then triages the patient to one of several levels. So there's level 3, there's level 1. This is the patient, for example, who has like no needs, no psychosocial needs, and everything is kind of dialed in. The social worker will be like, great, I'll call you a couple weeks before surgery and make sure that you're doing okay and have everything that you need. Whereas a higher need patient, the social worker may check in with them weekly. Social worker may reach out to the surgeon and say, I think we really need to sort out some of this stuff before moving forward with surgery. And we're trying to set up a framework and a kind of a state of affairs and a tone with patients that this is something that every patient goes for. And the goal is to get you to surgery, but make sure that you have a successful surgical period and successful recovery as well. Okay, so this is, there's no way, I was one of the co-authors of Standards of Care 8, but I was not involved in the typesetting and the publishing of the final document. I didn't want to go in and like re-enter this stuff and everything. This is this is what the recommendations look like in the published standards of care 8. So I didn't have anything to do with like graphic design for this, so I do apologize, but I do recommend that you familiarize yourself with the new standards of care guidelines that just came out in September. And in particular, chapter 5 is the assessment of adults for surgery. And so there are some interesting new developments. The primary take home here that I will point to you is that this letter that's required, like to affirm that somebody's really trans, that letter business still exists. Again, we think that letter is neither necessary nor sufficient for surgery, and our patients come and they say, here's my letter, I want surgery. We say, great, you're going to meet with our social worker just like everybody else does, and we're going to make sure you're ready for surgery. But what has happened is they have removed the requirement that letter come from a mental health clinician, and it now can come from any clinician with a master's degree or above in a relevant field. So that means it can be a surgeon. That means it could be a primary care physician. It could be a hormone prescriber. It could be a social worker, you know. So, theoretically, it could be like a nurse case manager who has an MSN. So what we are doing internally here at UCSF is the medicine physicians at the gender affirming health program. So we're over at Montgomery Street. We have a facility there where we see patients for primary care, hormone therapy. Then we have plastic surgery, doing chest surgery consults there. And we have gynecology and urology doing their bottom surgery consults there. And we also have general gynecology who rotates through there as well. So our medicine people, which is right now me and another physician, the other physician is family medicine, and then whose name is Steph Wynn, and they use they, them pronouns. And then we have a peds adult endocrinologist who's going to join us in August or September, and she's going to be there only one session a week, and we'll be primarily focusing on young adults and transitioning patients out of the child and adolescent gender center into adult care. So, but you can expect any medicine provider over there to be qualified to write these letters. So now the issue that we're bumping up into is the insurance companies have not caught up with the SOC 8. So the insurance companies, we tried to implement this. The insurance companies immediately said, SOC 8's too new. We haven't adopted it yet. You still need to get your mental health letters. So we're kind of dealing with that right now. Our social worker is licensed, but she was hired primarily for like case management type social work stuff, and she doesn't have a background in doing these kinds of assessments. So we're trying to get her up to speed so she can feel comfortable doing them. So we're hoping to be able to offer them, but we're hoping that before we get to that point, we'll have gotten the insurance companies up to speed, and then they'll start accepting letters from our medicine people. The other thing is that there used to be this kind of recommended 1 year on hormone therapy, and now it's gone down to recommended 6 months. I actually do not agree with that approach. I think that, it used to be 1 year, but you also could make exceptions. Now it's 6 months, but you also can make exceptions. I don't see any benefit from lowering it down to less than a year because you can still make exceptions. Now this 6 month thing, I think, is going to make a lot of people start knocking on the door at 6 months in a day saying, I want facial feminization surgery. And there may be people who have features that are very prominent, and it's totally appropriate to do FFS like when, at any time. But I think there also are some people who just come like plowing in. They're just like, I want to do everything tomorrow. And I do worry about people who like kind of get on this like rapid, like, I just want to do everything, not because I think that they're not trans, but just because it's a lot of change to throw into somebody's life all at once. But anyway, those are kind of the two highlights in the updated assessment requirements that I wanted to show you. So this is what I'm going to do. This is the end of the talk. So I'm going to just stop my share for a moment. We can go to Q&A, and I'm going to, by the time I finish this talk, Apex kicked me out. So I have to log back in. So let me log back into Apex so that at some point I can take 1 minute to show you how to document patients' gender information and name, etc., in the system. And in the meantime, we can go to Q&A. So thank you very much.
Questions for Dr. Deutsch?
Dr. Deutsch, I have a question. This is Galen Sanford Moore, the Grand Rounds Chief Resident. But I think the last point you were making about the timing, especially with surgery that we consider to be a little bit less reversible, how do you navigate that conversation with patients on timing of surgery and whether hormone effects really continue to
hold on, my
set
audio
in?
just kicked out. Hold on 1 second. So sorry. Okay, are you there?
We can hear you, Maddie.
Okay, you know, I think my computer wants to like update. It keeps booting my audio for some reason. You know, and anyway, I'm sorry. You were asking how to navigate these early surgery cases.
The conversations, yes, and also kind of whether there is benefit to waiting from a hormonal standpoint, whether the face will continue to feminize or whether the voice will continue to feminize.
Right. Yeah, I mean, a lot of that I actually defer to the surgeons and voice specialists here as far as like, you know, how much more change can you expect? You know, there's, and I defer to the voice folks, but, you know, to my knowledge, you know, there's really no voice feminization that occurs from hormones, though some of the kind of longitudinal testosterone driven changes to the voice across the lifespan are arrested when somebody, goes on, you know, when somebody's testosterone is removed from the mix. You know, I think voice considerations would probably come up more for trans-masc people who quite often are very unsatisfied with their voice. And I owe Sarah a reply email about some research that she wants to actually do on it. But, you know, there's a lot of room for improvement in our voice care for trans-masc people, because as we know, your vocal cords get thicker, but nothing else changes. And a lot of people are unsatisfied with their voice, and they've kind of heard like, oh, well, you take tea, your voice changes and it's all fixed, but that's not really what happens. For surgical considerations, I also defer to the facial surgery experts to decide like what aspects of facial features are bony in nature and or are really not going to be affected much by hormone therapy, as compared to there are certain features, especially soft tissue features, that may change with continued hormone therapy. And the real question comes up is, if somebody's on hormone therapy for a year or two, will bony features that were of concern previously no longer be of concern because there's been soft tissue changes? That's something that I defer to the surgeons to kind of talk to their patients about, and you're the experts. I think the challenge is when you have that patient who shows up at like 6 months in a day and is like, I want these procedures done now, and I have this vision of what my face is going to look like. Those are difficult discussions to have. And, you know, I have those discussions with my patients who have expectations about what hormones are going to do for them. And I try to tell them the truth, you know, like we don't really know, or there are limits that what can be done, because I think that kind of radical candor is important with patients. Did that answer the question?
Yes, thank you.
Great. Okay, I see. Should I let Clark? Do you want to? Yeah.
Jeff, go ahead.
Hey, Thanksgiving is coming up, which is for many of us the time of year where we go home and debate culture war issues with our families. So I was wondering if you could share some thoughts on gender affirming care and surgery in kids.
Yeah, I mean, this is like the $64,000 question, right? I mean, this issue has been totally overblown and politicized, and there's just not a there. Nobody is lunging at 15-year-old kids with surgical scalpels. Surgery under 18 in kids is rare, and it comes after extensive, appropriate evaluations. The data does support providing gender-affirming care to kids, regardless of how that data has been twisted. Most of the data that has been twisted in the public sphere around in this discussion, if you actually talk to the investigators whose data is being used as an argument against providing this care, they're frustrated because they're like, that's not what my paper said, and they're using my paper incorrectly. So the issue of surgery, it's rare. And it only happens in very specific, clear-cut cases after an extensive evaluation. So that would be kind of my statement. And then as far as facial surgery for kids is just not something that I see much of. Again, I defer to the facial surgery experts here for your decision making, but I don't really know that anybody's doing major bony work on a face for cosmetic purposes when those bones are still developing, because facial bones develop into your 20s. And again, I'm punching above my weight here. I don't want to, I'm like, like explaining to a bunch of facial surgeons how you guys should be explaining it to me. But just kind of that would be, how I would talk about this. I have Apex open. Clark,
Yeah.
what would you like to do
Yeah,
next?
Maddie, it's so good for us to show us the Apex issues, so we're all familiar with it. So
Yeah.
I would say let's do that first, and then
Great.
people can hang on for questions after if they don't mind.
I'll do it super quick. I can stay a little late and people can contact me directly too. When you're in Apex, if you click here on the line that has either the pronouns or the gender, you get this thing called the SOGI Navigator, and that's where you can enter the name, Sally, whatever. You can adjust their pronouns, and then you can document their stated gender identity, sex assigned at birth, sexual orientation, as well as an organ inventory. This stuff should be collected by registration teams, the name and pronouns, so we know how to communicate with patients. But the gender identity, sexual orientation, organ inventory, that should only be collected by a clinician with a patient, or ideally, and I just about to publish a study that found this, patients overwhelmingly want to provide this information anonymously, just by like pen and paper form or by the portal. So, but if you want to enter and update this information, this is where it goes. The reason having this information is so important is so that when we do population health studies, we want to like look at outcomes, whatever, you want to pull a bunch of quality improvement or research stuff. If you don't have the data, then it's very difficult to identify who is what. So that is why it's so important to collect this. So that's my spiel.
That's great.
On that.
And Maddie, you think it's okay for otolaryngologists to populate that information? Basically, more people doing it accurately, the better.
Yeah, and we're trying to actually have a universal MyChart blast sent to patients so they can enter this through their MyChart portal. We're working on that right now.
Great, that's awesome. Neil, I think your hand was up next.
Thanks. Hi, Dr. Deutsch. Thanks for that interesting talk. My name is Neil Patel. I'm one of the fourth-year residents. One of the discussion points that we've had in the facial plastics division is how patients are getting their gender-affirming surgeries and in what order. So I was wondering if you had, through all of your experience, any thoughts on the order in which patients are interacting with their surgeons in terms of top-bottom surgery, facial surgery, and is it, in your mind, a function of SOC7 not appropriately addressing facial feminization and masculinization surgery, or is it a patient preference? Patients wear their faces to the public, so you would think that that's very important, but it's one of the things that we're going to start thinking about and investigating. Just wanted to know your initial thoughts.
Yeah, that's a great point. So SOC7, you're correct, did not make a clear statement that facial surgery is an important pillar of gender affirming care, which was a huge shortcoming. They did put out a clarification statement in 2016 that was basically an addendum, but it was kind of tucked into a corner and they didn't do a great job of highlighting it. So it did cause a lot of problems. SOC8 is much more clear that facial surgery is a medically necessary pillar of care. As far as the order, it's very individualized. There are patients who genital surgery is a priority for them, and then they want to do facial surgery at some later time. There are patients who only want chest or genital surgery and don't want facial surgery, patients who only want facial surgery. There are patients who want genital surgery who an objective panel might look at their facial features and universally agree that they have masculine features, but the patient doesn't care. So it's very individualized. I think a question that comes up is doing joint cases. And I encourage you all to reach out to, right now, Esther Kim is the plastic surgeon who's doing the chest cases, and then Gaetan Pettigrew and GYN and Christy Butler in urology are doing the bottom surgery cases. And in the community, it's not that common anymore. It used to be more common, but there are people in the community who get multiple procedures done at the same time. To me, it sounds like a nightmare. But, and then questions come up about like, do you want to be operating on the pelvis and the face at the same time from like a cleanliness perspective? So, but there've been some articles published on people getting hysterectomies and top surgery at the same time, and they do the chest first and then they do the hysterectomy second. So that would be something, you might want to reach out to your surgery colleagues and talk to them about coordinating cases, especially if somebody's coming just for like a reduction thyrochondroplasty, or they're just going for just a rhino or something, or like a minor facial, not a full 12-hour case. That might be something that, somebody's like, oh, I could get my chest surgery, I can get my breast aug and my face done at the same time in one anesthesia event. So,
right, that's interesting. Yeah.
Yeah, we have not had those conversations to date. Patients ask me if they can have their chondrolarynoplasty and their glottoplasty at the same time, and that for me, that's too much work. In the larynx at the same time. It's a setup for disaster. It's not work on my part, but I just think it's too much on that body part to have external and internal surgery at the same time. Anna, did you have a question? Are you still on? Anna had a question, but we may have lost her. Other questions before we show the QR code and go on our way to take care of patients? All right, everybody has someplace to go. Maddie, we have the blessing of seeing you again tomorrow.
Are we seeing each other